nice to meet you all. So my name's Melissa Bett, and I was the National Clinical Lead for Mental Health Matters, but I've since changed roles. So I'm the Clinical Lead for NHS Sefton Talking Therapies. I'm also a high intensity cognitive behavioural therapist and a couples cognitive behavioural therapist as well. So what I'm going to run through today is a little bit about Mental Health Matters, my role, how my career developed, what talking therapies is, tips on experience, overall tips, and some useful websites that you might want to have a look at. And then there'll be time for some questions. So who are Mental Health Matters? Well, we're a national charity which provides over 30 mental health services across the UK. We provide a 24/7 mental health helpline, and that includes a specific military veterans helpline. We also provide non-clinical crisis havens, and the government has recently put a lot of money into crisis havens, so non-clinical crisis services, to divert people away from A&E, in which A&E is not suitable for them because they require emotional support at that moment in time. Mental Health Matters also provides the contract for Warrington NHS Talking Therapies, Sefton Talking Therapies, Northumberland, and also in partnership with Staffordshire Talking Therapy Services. MHM also does floating support, employment services, community inclusion, and reablement services. So Mental Health Matters as a whole supports over 15,000 people every month to access some form of mental health support. So what is NHS Talking Therapies? Now, you might have heard of this as IAPT, which used to stand for Improving Access to Psychological Therapies. That was rebranded a couple of years ago now, so all talking therapy services are called NHS Talking Therapy Services, and it usually includes the location. So the Talking Therapies programme began in 2008, and basically since then has transformed the treatment of anxiety and depressive disorders. Talking Therapies provides evidence-based treatment, and they always offer the least intensive and most effective treatment first. So that just means that people get treatment quicker and it's more effective for them the quicker they get the treatment. So prior to talking therapies, people were sat on sort of 12 to 24, if not more than that, waiting lists for cognitive therapy, cognitive behavioural therapy, or other forms of psychological therapies. Whereas now, talking therapies has targets to meet. So we have targets to get people into an assessment and treatment and into treatment psychological therapies within a certain time frame. Now, over 1 million people now access talking therapy service every year. It's actually in excess of over 1 million now. Talking therapy services are staffed by psychological wellbeing practitioners, which are generally called PWPs, high intensity therapists, which are called HITs, and counsellors and other people, other practitioners with modalities, which I'll talk a little bit about. As I mentioned, we always offer the least intrusive, most effective treatment first. So a lot of people will work through talking therapies in a stepped care model. So they might receive low intensity treatment, and if that's not effective, they can always be stepped up for a higher intensity therapy. So this is what the services usually will look like within talking therapies. So we have step one, which is primary care. It's sort of the assessment, watchful waiting, which might happen across individuals' GP practices. Then within talking therapy services, we have a step two. So that's our low intensity CBT offer. And within that step, it's staffed by psychological wellbeing practitioners, and they provide treatment for depression, which is generally mild to moderate, panic disorders, generalized anxiety disorder, so when somebody has excessive and uncontrollable worries about lots of different things. And they also treat obsessive compulsive disorder, which is mild in presentation. So that's where somebody has obsessional thoughts, which then leads to compulsive behaviours. And our PWPs who work across the Step 2 service offer a range of different interventions. So they offer interventions on a one-to-one basis. They offer group treatment. They offer online cognitive behavioural therapy, a huge range of interventions that we can offer clients. Now, then we have our step 3 high intensity CBT level. And that is for those clients who haven't recovered at step 2, or actually their presentation needs step 3 initially. So that could be because they're experiencing post-traumatic stress disorder or social phobia, which isn't treated at step 2. Or they might have depression that has not responded to the lower intensity treatment. So patients can very much move up and down our services to ensure that they get the most appropriate treatment. And within Sefton, we also have step 4, which is our sort of a highest level of therapy, and that includes longer sessions. It includes cognitive behavioural therapy, EMDR, which is a treatment for PTSD, and equally also schema therapy. So we have some additional modalities at step 4 as well. And we also have counselling, which sits within our step 3 service. So we've got lots of levels, lots of interventions on offer. So I am the clinical lead for NHS Sefton Talking Therapies, and within my role, I'm also a high intensity CBT therapist. So I hold a caseload of patients in which I assess, diagnose and treat common mental health problems. So I treat depression, people with bipolar who's in a depressive phase, anxiety disorders such as obsessive compulsive disorder, post-traumatic stress disorder, health anxiety, which is when somebody is preoccupied that they have or they're going to get unwell, generalized anxiety disorder, specific phobias, which can be anything from animals, it could be a spider phobia, all the way up to vomit phobia or needle phobia. So I cover all the phobias. As well as social phobia, where somebody is very anxious in social situations because they fear that their performance is going to be judged. Body dysmorphic disorder, in which somebody feels that they have a impairment or disfigurement in their body on their appearance, which then impacts the way they behave and feel and think. As well as panic disorder. So that's somebody who experiences panic attacks that may be triggered by specific situations, or they might come out of the blue. So within my role, I will hold a small caseload of complex presentations. I can see patients for up to 6 months. I also work alongside GPs, psychiatrists, social workers, health visitors. I'm also responsible for completing expert reports. So that might be criminal injury report. It could be a report for social services or a report for safeguarding, as well as ensuring that discharge letters are sent when a patient finishes with myself. I provide and complete risk assessments for every clinical contact of my own patients, as well as any patients who may access our service. At a moment of crisis, I would be responsible for risk assessing them as well. I'm also a couples CBT therapist, so I work with couples that are depressed, and that either could be because of problems within their relationship, or the depression itself has become the problem within that relationship. So I work with the couple to treat the depression. I also provide online CBT, and I will supervise practitioners across our service. So a lot of you will have heard what cognitive behavioural therapy is. CBT is the effective treatment for both depression and anxiety disorders, and it works on the principle that anxiety disorders and depression becomes a cycle between how we think, how we feel physically, how we feel emotionally, and how we behave. And it becomes this vicious cycle, and CBT provides the evidence-based techniques to alter and change this cycle and therefore recover from the depression and the anxiety. So, for example, somebody may be driving home from university. They might then experience a thought that pops into their mind around, what if I've hit somebody with my car? I'm a murderer. I'll go to jail. Now, these thoughts understandably will cause that individual to feel anxious. They'll have maybe feel a bit sick, shake, racing heart, feel quite breathless. They'll feel afraid. Now, for some people, when they experience these thoughts and they experience that physical sensation and that emotion, it will then lead them to develop certain behaviors, so certain compulsions, which might include they might go back on their journey to check that they've not hit anybody. They might feel that one check isn't enough, so they check again. They might feel that check's not enough, so they'll check police or social media for hit and runs. They might ask their family members, do you think I've hit them? Do you think I've hit somebody? They might double check their car. They might then say something or a phrase or count a certain amount of numbers in their mind to prevent their feared consequence of having hit somebody with their car. So this is an example of somebody who would be experiencing symptoms of obsessive compulsive disorder. So you can start to see how this can become a vicious cycle for individuals. And cognitive behavioural therapy gives them the treatment to be able to break this cycle. So we would do that by getting them to sit with their thoughts, their obsessional thoughts, in an exposure element, and then prevent their rituals and therefore breaking this cycle. It reduces the anxiety to those thoughts. They feel that actually they don't need to engage in these compulsions anymore, and it breaks that cycle for them. So within my role as clinical lead, I work with our managers across the service to ensure that our service provides excellence and that we are continuously improving our service. I provide clinical guidance to all of the practitioners across our service. So that might be which treatment protocol to use. It might be that they're struggling with engagement with a client. It could be that they think a client needs to be referred on to another service. I supervise quite a few of the practitioners across the service. I lead on clinical changes and clinical processes. I'm also responsible for responding to incidents in the community. So the Sefton service covers Southport and Formby, and we became the psychological response for adults that were impacted by the Southport incident last July. So we became that specific service that provided that response, that psychological response. I'm also responsible for ensuring that we would maintain quality and clinical assurances. I'll do regular audits. I will develop new policies and procedures or new service models. We're constantly looking at innovation with the service as well. So that's my main role, is to develop innovations and clinical models. I'm also a NICE stakeholder. So I've done quite a bit of work around NICE and new clinical guidance. I oversee safeguarding adults and children incidents across the service and any other incidents that may occur across our service. So I thought this might give you a bit of an insight into my kind of day. So a day in the life of me. Always starts with coffee. And this is actually my day yesterday. So I reviewed emails, I responded to clinical guidance requests that had come in on Friday, as I don't work Fridays. I gave some debrief around an incident regarding risk on Friday, and then went into a service planning meeting, did some more emails. I then completed a clinical processes meeting with our step 3 practitioners, provided some guidance around a treatment plan. There was a client who presented with risk, so I supported our deputy clinical lead in terms of how they manage that situation. I then had my own supervision, so I talked about 2 of my patients on my caseload who I discharged after completing PTSD treatment with them, and they had recovered. I also talked about 1 new patient that I've recently picked up in my treatment plan. I then did a solicitor's criminal injury report, reviewed some service incidents. I then had an appointment with a patient who was experiencing symptoms of PTSD. And to treat PTSD, what happens when someone experiences PTSD is that traumatic memory is stored in the present part of their brain and it should be in the past part. So what we need to do with therapy is allow them to relive that traumatic event in a very structured manner to then reduce any fear associated with that memory, and then the brain is able to process that. So we did some reliving work in that session, and then I did some clinical emails and guidance after that. So I did eat at some point yesterday, but that just gives you a bit of a snapshot of what my day is like. So in terms of how my career developed, now in 2009, I was right where you are all. I graduated in clinical and health psychology. I should have took the years off, so you can't guess my age. But following graduating in clinical and health psychology, I then became a community support worker for adults with mental health difficulties. Then went on to be a clinical support worker for inpatient for child and adolescent services. Then in 2011, I became a trainee psychological wellbeing practitioner, and I worked in our Warrington service then. So within that training year, you do a postgraduate certificate, in which I did at John Moores. And then the rest of your days, you have 2 days a week in university. The rest of the week, you are in clinical practice. You are starting to develop these skills and the abilities to assess and treat individuals with anxiety and depression. Also worked at 1 day a week in a prison and a youth offender unit within this training year. Then 2012, I qualified and then became a supervisor for PWPs. I did an additional postgraduate certificate in advanced practice in Manchester Uni. Then in 2015, I became a trainee high intensity CBT therapist. And again, you do a training year. So I did a postgraduate diploma in CBT at Chester University. So that's 2 days a week in university and then 3 days a week in clinical practice, assessing and treating patients with anxiety disorders. Then in 2016, I became a step lead. So I had a management role across the PWPs within the service. Then in 2018 to 2021, I then became the deputy clinical lead for Warrington. I did my couples therapy course. And then in 2021, I became the national clinical lead for mental health matters. Did that for a couple of years, and it included a lot of travel because obviously the service is across the UK. Felt it was taking me a little bit too far away from talking therapies, which is what I love. So then I moved into the role as clinical lead for NHS Sefton Talking Therapies last year, and I am still there currently and plan to be there for the foreseeable future. In terms of the talking career progressions, so if this is something that you're interested in, you would start off as a PWP, so you'd be a trainee. And you'd be on a band 4 NHS wage while training. Following your qualification, you'd then become a band 5, so there'd be a pay rise. Then there's an opportunity if you wanted to be a senior, that again would be another pay rise following that. And after 2 years post-qualification as a psychological wellbeing practitioner, you can apply then to do the high intensity CBT course. Again, that's a band 6 whilst training, and then a band 7 on qualification. Within talking therapies, we also have counsellors, so those that are trained in counselling for depression, interpersonal psychotherapy, or dynamic interpersonal therapy, or couples therapy for depression. And generally that might be individuals who's done a PWP role before, they do a counselling certificate, and then they go on to do that additional training within the service. Or it might be somebody who's currently qualified as a counsellor, then they go to do the counselling for depression course. All qualifications are currently funded by NHS England, and you also receive a salary. So your training is funded and then you get a wage as well. And there's that career progression. If you are interested, you can go on to be a step lead, so have a management role. You could be deputy clinical lead or a clinical lead or service manager. And within the kind of the benefits of talking therapies is that there is that additional training. So either it's been funded by NHS England or funded by the service. So there's options to do top-up training courses such as couples therapy, EMDR. You would have CPD events, and there's that incremental uplifts that the NHS provides as well. So in terms of if this is something you're interested in, it's really essential to look at gaining experience. So you want to look at relevant mental health experience, and that could either be voluntary or paid. That could be something you would do with the Samaritans or Childline or university helplines. You might want to look for a clinical support worker post, which might be within housing services, community or inpatient. You might want to become a recovery worker in a crisis haven, again, to get that clinical experience. Or computerized cognitive behavioral posts might be available, or sometimes talking therapies offer assistant PWP posts or apprenticeships within the PWP role. So it's if this is something you're interested in, look at these opportunities to gain that experience. In terms of overall tips, talking therapies is a very competitive area. We get hundreds of applications for trainee PWP posts, and generally those roles will close, within 24 hours. So if this is something that you're interested in, have a look at the person specification for a trainee PWP. How will you be able to meet that role? And equally, not all talking therapy services are provided by the NHS. So have a little look at your local service. It might be with a charity, it could be with Merseycare, for example, in the Liverpool area. So have a little look at what's local to you. Ensuring that if this is something that you are interested in and you have the relevant experience based on the person's spec, make sure you get your application in fast. Ensure you know the job description and role. Research talking therapies, research NICE guidelines, use your clinical example from your experience that you've developed. Talking therapies is fast paced. It can be highly pressured in terms of seeing the patients that we see, ensuring that we are managing risk and ensuring that they are moving towards recovery. It is challenging, but it's a job with great rewards. So I've just included some useful websites as well for you to have a little look at. So it talks about talking therapies, it talks about how to find kind of jobs on NHS, and equally MHM itself as an organisation. So that's the main presentation. Is there any